Okay, let me double check and get on chat. Get the chat thing going. There we are. Great. Can everybody hear me? If someone would give me a hi sign. Great. Thank you, Eddie, Carmen, Janelle. Excellent. Okay. Ladies and gentlemen, we're on the downslope for our weekend course on the ethical and legal interprofessional issues of psychopharmacology. How's it going? Maybe a quick check-in, 3/4 of the way through. Are we all happy, healthy enough, etc.? Good, good, good. All is good. Great. Thank you. Yeah, I feel that way too. This is a kind of a challenging course to put together and to teach because it's frankly not the most exciting and not specifically as patient-oriented as maybe we would all like in a way. I do think it's critically important to have this foundation and grounding of looking at the ethics and morality, if you will, of prescribing mental health medications. My God, you're prescribing medications to affect someone's thinking and their mind. And it brings up a ton of controversy, I think legitimate controversy, with some honest differences of opinion and some dishonest and ultra-biased differences of opinion. But this is life, and this is what we are signed on for. And I think that it can, one can ethically prescribe and recommend psychotropic medication in select cases in order to stabilize systems. Remember that point that I keep raising from the childhood and adolescent work, in order to help someone rise to their best potential, their highest potential. And I think that one can make the analogous remarks around things like antibiotics for bacterial illnesses that can really significantly turn things around so that the body can heal and use its own healing mechanisms without being bombarded by this outside invader. We can't make a perfect analogy with regard to mental health conditions. There's not cures per se, but there is movement back to normal developmental trajectories and functioning in life. So I am a big proponent of psychopharmacology, but I do it hopefully with some degree of humility, caution, respect for the individual's rights to refuse medication. All right, I could go further with this meandering, but let's get into the material now for decision trees, practice guidelines, and algorithms, and I'm on slide 69. If you're following me along. All right. Decision trees, an emerging tool in behavioral health care. The use of algorithms for medication management of people with serious mental illness. These treatment algorithms, also referred to as practice guidelines, are quite simply a series of treatment steps, each of which is defined by the clinical response of the patient to the preceding step. Now, traditionally, practice guidelines have been developed to treat physical illnesses, such as diabetes, coma, the Glasgow scale in emergency rooms, etc. And they have emerged over the past 20 plus years in behavioral healthcare settings in the context of mental health medications. In the behavioral health practice guidelines, they were originally developed by state mental health program directors. And their purpose was to improve mental health, substance abuse, and disability and developmental disability systems throughout the nation. Their impetus was to create cost-contained, quality-driven, outcome-oriented mental health services in a rapidly changing environment. Because medication treatment not only has had a significant impact on the quality of life of patients, but significantly enhances the effectiveness of other treatments, medication treatment has typically been the first selected for the development of algorithms, clinical guidelines. These kind of systems have been used, as I say, for many years with chronic medical illnesses, diabetes, cardiac care, emergency room triage, and have been found to be extremely helpful. So it behooves us to jump into it and learn what we can about it. If a clinical guideline is solid, and we'll talk about ones that aren't solid, but if one is solid, it will help with decision making, the choice of medications, dosages. It will reduce unnecessary variation. It will improve outcomes to have some standardization. And ironically, it will also individualize treatment, because you don't just plug a group of people into an algorithm. You plug an algorithm into an individual patient situation and what is next for that individual. It's subtle but different. And if it works well, it's less expensive, it's more efficient. All right. So let's talk about increasing the accountability. To make the clinical decisions explicit, there should be a if-then type of practice guideline. If this condition is met, if that situation is met, if this symptom complex is observed, should point you in this particular direction or a particular direction. It can provide the framework for comparing patient progress. Why are they not progressing? What is wrong? It can help you decide to move on to other medications if things aren't working well. So it's not a static, it's a dynamic sort of process. Can also provide a framework for defining costs of treatment. And it also is the framework for identifying good documentation. You can see how managed care insurance companies would be particularly interested in practice guidelines. They would be looking for that kind of uniformity and a cookbook, if you will. And I hesitate to say cookbook because that is some of the dangers and potential shortcomings for such guidelines. What is the, always follow the money, right? In everything. But who developed these guidelines? What is their interest in developing them? Is it cost containment only? Is it shifting people to certain medications, maybe generic medications from brand name medications, newer medications, etc.? Is there sufficient evidence, scientific evidence, good research that back up the use of this medication at this dosage within this guideline? Are the opinions biased? Well, as I've mentioned, all opinions are biased. Whether it's subtle or not so subtle, whether they're aware or not aware, there is bias built into our system. And it's our job as mental health professionals to sort out the opinions, to see what is biased, overly biased, reasonably biased, acceptably biased, etc. And it could produce a potential shortcoming in that it could increase costs and utilization of services. It could make things harder and more difficult, more extensive, longer hospitalizations, etc., to go through a cookbook, if you will. What if it substitutes for clinical judgment? What if you don't know what the heck you're doing and you simply rely in a cookbook fashion on a clinical judgment, use it for clinical judgment? What if it's, for you, it's a recipe and all you do is follow the recipe and patient be damned, symptoms be damned after maybe the initial diagnosis, because practice guidelines are designed for treatment of specific, in the behavioral health world, specific behavioral health diagnoses and their treatment. So be careful about getting lazy and using guidelines to direct you. What if the standard of care is inadequate and the practice guideline that arises from that is inadequate? What if you used a clinical guideline that you garbage in equals garbage out, meaning that the diagnosis is wrong? Perhaps that person has, instead of a panic disorder, severe anxiety disorder, perhaps they have a psychotic disorder. Perhaps they have a high functioning, a diagnosis of high functioning paranoid schizophrenia. And what appears to be anxiety, is apparent as anxiety, is actually underneath psychosis. That clinical guideline would steer you probably in the wrong direction. And clinical guidelines have to be updated constantly with new information, new medications, new ways of thinking about treatments and treatment modalities, if you will. Moving on to legal issues. What if your hospital, your treatment facility, your clinic embraced clinical guidelines and you didn't use them? You chose not to use them and some untoward event occurred. That would set you up for potential liability when otherwise you would not have that problem. Doctor, why did you not follow the clinical guideline for the Cherryfield mental health clinic? You had a clinical guideline, you didn't follow it. Ergo, you fell below the standard of care and you have committed malpractice. If an untoward event should occur, suicide, a death, etc. If you do deviate from the clinical guideline, you need to clearly document why you're doing it and explain why you're going outside of the guideline with a good clinical rationale with this patient's experiences, symptom complex, etc., detailed to help illustrate your point of why you went outside the guidelines. If you follow the guidelines and things don't work out, it gives you increased protection from a legal point of view, a malpractice point of view. So you have both aspects to this. All right. Um, so how to implement clinical guidelines so that they are the most effective, the best practice, the best science. First thing is you include all the stakeholders in who are involved in the clinical guideline. The academic setting, research, scientific papers that reflect on the topic, um, the the professionals, the mental health professionals, their viewpoint on it, because they're the ones that follow it or don't follow it. The patient's families, the patient's parents, if it's a kid, um, the guardians for intellectually disabled individuals or otherwise disabled individuals. Um, the payers, the insurance companies, the government, and its Medicare and Medicaid systems. It's worthless to come up with a guideline that suggests the use of different medications, different doses that are not compensated, not paid for, not acceptable, not PDR, not approved by the FDA. If you go outside a FDA indication for a medication, such as Catapres or Clonidine, an alpha agonist for ADHD, and you want to put it in the guideline, you have to have some good backup in terms of research studies verifying its effectiveness and safety. It's not that you have to use only on label, so to speak, medications. After all, how could you do that when 80% of the time off label medications, off indication medications, perhaps they're approved for adults, that antidepressant, but not for children or not for adolescents? You can put that into your practice guideline, but you need to have your ducks in a row in terms of the research to back it up. The case studies, if only the case studies, if you don't have double blind placebo-controlled studies, which you often don't, you need to put in sufficient backup and references with case studies to verify effectiveness and safety. So it's critically important to include the stakeholders in the development and testing. It fits an analogous situation. I make it a point never to send an email about someone else that I'm not willing to CC that person. I may not actually send them a copy, CC them on an email, but I write the email as though they could have been CC'd. It keeps me honest, it keeps me respectful, it keeps me aware of all stakeholders. So the other day, as a quick aside, I got an email from one of my siblings who has a friend who's a conspiracy theorist. This conspiracy theorist friend had sent her an article about coronavirus, that coronavirus pandemic was not a virus at all, but rather toxic waste extruded from normal cells and causing symptoms of coronavirus and the pandemic, caused by, get this, 5G, the new phone system network with new satellites up in the sky that this conspiracy theorist friend of my sister's said was bombarding the earth with new EMF, electrical radiation forces, that was disrupting normal cells, causing them to extrude toxins that were the equivalent of the coronavirus pandemic. And there weren't any things, and there things such as viruses don't exist at all. They're just toxic waste from cells. And this friend sent along a YouTube video from a physician who promoted this idea, saying that it's similar to what happened in 1918 with the Spanish flu pandemic. And he said that was caused by electricity, how the world was being electrified in 1918. And if you didn't believe that, it was then caused by radio waves. And radios were becoming popular in the late teens, in the 19 teens. So I did a very quick and dirty Google search on this physician and this conspiracy theory, and learned within 5 minutes that radios did not start occurring in the world until 1920, so it couldn't be radio waves, and that electricity began before 1918, years before, and therefore it could not explain this sudden pandemic of the Spanish flu. Yeah, so Janelle, there's a theory going around that it was created to kill people in upper management to make room for younger people to promote more quickly. And it was genetically created in a lab, Eddie says. Yep. So the wonderful thing about the internet and the awful thing about the internet is that it's got everything for everybody. And the millennials caused it, to get rid of us boomers, right? Get out of the way, boomers. So knowing my sister and loving my sister, and knowing this friend also from afar, I did not want to say this is a crock of crap and a stupid conspiracy theory. I wrote a very respectful return email to my sister saying, I just checked this out on the internet and found this, that, and the other to refute this, that, and the other idea behind this theory. It seems to me that this theory doesn't hold up to the evidence at hand. And I left it at that. Well, she told me later that she's forwarded my email back to her friend, and her friend's response was, I knew he'd say that. That's what he always says. But my sister said, I felt comfortable enough with your response, done in a respectful manner, that I could forward it along and not have to get too wound up in it and involved in it, which I thought was great. And so again, back to my own thought of it's our job, my job, to educate people around me on issues, but we should do it. It would be wise to do it in a respectful, somewhat humble manner, and then leave it. Okay. Decision trees, practice guidelines, and algorithms should involve pharmacology education. Why are you doing this? Why are you making this switch? There's logic to it. Follows this guideline. How am I doing it? You have to make sure the medication's available, the dosage is available, the cost is acceptable. These are all stakeholder positions that have to be accounted for. Now, it can take longer to follow a clinical guideline than to simply listen to a patient. And we've all heard of this idea and perhaps even been involved within it, where you're so interacting with the guideline, the algorithm, et cetera, that you're not really listening to the patient, and you're just, or you're wanting to push the patient into the guideline and fit the guideline. Oh, that symptom doesn't really matter because, by the way, it's not in the guideline. We'll ignore that one. So you have to be really careful about this. And if you do this in an inelegant, clumsy, impersonal way, you can have longer visits, less effective visits, and not do the job. So I say do the job right the first time, have a guideline that is truly addresses all the stakeholder positions, reasonable stakeholder positions. It may cost a bit more in the short run, but it's more successful in the long run, at least in theory. So remember, when we're talking about treatment here, we're not talking about a leaky roof or a falling down fence that just needs to be nailed up a bit or patched a little bit. We're talking about human beings, their functioning and their quality of life. And we can't just approach it in a strictly cookbook fashion. We can use cookbooks to help guide us. I mean, the best chef, if you think about it, is someone who looks at a cookbook, reads it sort of like a novel, and says, oh yeah, right, that spice, oh yeah, that quantity, oh yeah. And then they do their own thing based on their own years of experience and expertise. Those are some of the most wonderful recipes and cooking around, is guided by a cookbook or a guideline, but not totally followed in every sense. Now, that doesn't work in all cooking. We know that. Baking, for example, is something that you really need to follow the quantity and the temperatures and the time and all that. I'm talking about spices and the flavors of a recipe and perhaps the general ingredients in a recipe. I'm not talking about the detailed mechanics of, say, baking, etc. You mess around with a pie crust and you've got a crappy pie crust. Or 6 months ago, I made some Scotch shortbread that was just atrocious. And I thought I was following my mom's recipe, but I wasn't following it carefully enough. And and the result was obvious and crappy. All right. Question, ungraded question. The cost of psychotropic medication, including copays, is a significant factor in patients taking prescribed medication. True or false? Yep, it's true, right? So if you have in your clinical algorithm a medication that the copay is unreasonable, the cost is unreasonable, it's unavailable, it's not going to be taken. It's not. You're going to have an unsuccessful clinical algorithm. You're going to have an unsuccessful treatment, right? Okay. So what are some other implementation issues? To consult about the algorithm, run it up the flagpole, check it out as a draft for a good amount of time. Let it, let sleep on it. Revisit it. Send it around to your colleagues. What am I missing? What am I overemphasizing? What am I underemphasizing? how to get people to follow it. This is consumer and family education. Get them on board with it. They're stakeholders also, right? Biggest reason medications don't work is people don't take the medications. 50% can be attributed, a medication lack of effectiveness is not taking it in the first place. And that often has to do with lack of including the patient, the family, etc., in on the decision-making process and your rationale. So bring them in on this. So quality care and efficacy rather than cost should be the major defining principle of an algorithm. They shouldn't be static. It should regularly evolve, should be updated, incorporate new medications, new scientific evidence. Brings me to another point around managed care. Sometimes managed care will deny a request for a requested medication, either because it doesn't fit their clinical algorithm or it doesn't fit some other, established clinical algorithm from some professional society, ASAM, the American Society of Addiction Medicine, for example, etc. And this can be troublesome if you go too far afield and don't follow the clinical algorithm, and God forbid that you're not aware that there is a clinical algorithm. So folks, we're stuck with these whether we like them or not, so let's make them the best they can be and be helpful and the rest, because this is the future that we're living right now, is cookbooks and practice guidelines, etc. So I say embrace them, write them yourselves, be willing in your agency, your hospital, etc., to be on the committee for developing such algorithms and get your input in on it. Nothing like being in charge of something to get your take your bias on it. Don't leave it to others because you think it's a pain, and because they won't do as good a job as you, right? Okay, I say that in all narcissism, but there is some truth in it. Volunteer to be part of this. It'll actually be a kick. You'll learn a lot. You'll be a hero. You will have taken workload from other people who don't really want to do it and aren't going to do a good enough job with it. If you're going to do it right. The art of the good enough. Do it better than average, right? Doesn't have to be perfect, but it should be an advancement. It should push things forward into a better treatment. All right. So let's start going through a couple of these clinical algorithms. All right, in your reference section, I believe it's 4. Yeah. There are 113 pages that comprise clinical algorithms for almost every mental health disorder you can think of. Look at the ones on this slide, 5 bullet points. The ones on the next slide, 5 bullet points. Everything you want to know about prescribing for these conditions are on these clinical algorithms. They're really quite nicely done. I've pulled them from all different areas. Um, some of them I have helped write for insurance companies. And I'm just going to hand walk us through the first one, obsessive compulsive disorder, as an example. You don't really need to look at this. You're not going to be tested on it in the reference section. But the first one on obsessive compulsive disorder goes on for let me just see, goes on for 14 pages, and it has literally about 5 pages of references, even including for children and adolescents. So it's got a wealth of information. It's brought from all different stakeholder positions and resources, and it's got wonderful things within it, like an OCD checklist, right? Activity checklist, symptom checklist. Has a whole section on talk therapy related to obsessive compulsive disorder, right? And then it goes into a very nice list of antidepressant drug therapy options for OCD, with the prominent one at the top being anafranil, clomipramine, which is my go-to medication for severe obsessive compulsive disorder. With dosages, what to start with, initial dosing, what is maintenance dosing, what is maximum dosing, any precautions such as weight gain, things of that nature. And it's really very helpful. It should be so helpful to you that when you assess a patient, give that person a diagnosis of obsessive compulsive disorder, it would be very smart to look at these references and go through kind of a checklist to make sure you're not missing anything, and you've really got it solidly, not only solidly diagnosed and assessed, but you're doing the right psychotherapy, most effective psychotherapy, and the most effective medication help with it. And that's just for one of them, obsessive compulsive disorder. All right. So I highly recommend these to you. Like I say, you're not going to be tested on any of them, but I find them very useful, and I've collected them over the years to have the best ones that I could find, the least biased ones, the most helpful ones. Not just for medications per se, but for the whole ball of wax in terms of treatment for this, with a lot of references and referrals, OCD websites, patient and family referral websites related to it. Glance through this in your free time, and I think you'll find it very helpful. By the way, another helpful thing about practice guidelines for the non-prescribers is that these practice guidelines, the ones particularly I was involved with insurance companies, they were written for non-physician mental health professionals to improve their education and when to make a referral for medications. This is the gold I was waiting for, Janelle. Thank you. Yeah, I hope so. I hope so. This, and by the way, these days, when I want to hone in on the best treatment, I will, and if I haven't, particularly now being semi-retired and not seeing direct patients anymore, I get a little bit hesitant and a little bit shy and conservative when I recommend things, because I haven't been in the trenches for the past couple of years, diagnosing, treating, medicating, making mistakes, blah, blah, blah. And I want some reinforcement, some backup. And so I'll go on the internet and I'll type in a diagnosis, I'll type in a medication, and I'll just quickly review it. Oh yeah, top dose, initial starting dose, maintenance dose, blood level if indicated. Psychotherapy is particularly helpful, dialectical behavior therapy, etc. And um, and it's a great reinforcer. So you can come up with your own, not your own, but you can come up with practice guidelines on the internet separate from these um, that are that are pretty good, and it's worth your while to look at. So as Janelle sort of nailed it, this is the gold I was waiting for. These 113 pages for all the major mental health diagnoses and their practice guidelines from soup to nuts with each one, I think are incredibly helpful and a great teaching tool, great education, and keep you honest and you're not missing anything. So I would recommend that you thumb through these, get kind of familiar with them, and double check them periodically. Just as I now make it a hard and fast rule to look up any medication that I'm not sure how to spell, and I want to know the cost of it. Those are the two things that I really focus on these days. Um, I also recommend you do that for practice guidelines to, to double check yourself. Um, yeah, it makes being prescribing real helps me integrate what I've been learning over the past 2.5 years. Exactly right. Exactly right. Don't reinvent the wheel. You don't have to be heroes in this. You don't have to know it all and do it all. You just have to know where to find it. It goes back to that axiom, know what you know and do it well, and know what you don't know or don't know enough about and look it up or find it or get help with it. There's no, in the art of the good enough, you don't have to be perfect with all things. In fact, you can't be perfect with all things and keep moving and accomplish the work. You just have to know where it is. And that's why I kind of torture you all with this incredibly long 350-page reference guide for this course. You don't have to know what's inside of this guide. You just have to know what's um, where it is and what to look for and what to check with quickly. It'll make you seem like you're smarter than you are, and you'll accomplish the job better. And by the way, in a risk liability world, isn't it wonderful to be able to say, I consulted with my reference, guidelines, and this is what I've come up with. I didn't just pull this a rabbit out of a hat. I didn't just do this out of my years of experience, although I did. I did it with some grounding. I relied on the kindness of strangers who were as smart, if not smarter than me, and maybe smarter in different areas. I relied on the experts. And it's through the practice guidelines that I got this. Okay. Um, all right. Let's. So, another big area is dual diagnosis. The increasing need, in my opinion, for mental health disorders and substance-related disorders to be treated simultaneously, not to be carved out by our old archaic system of whatever treatment door you go in is the treatment you receive, whether that's a mental health treatment or substance use disorder treatment. That's artificial. You don't split the baby like that. The best treatment programs are all dual diagnosis treatment programs that simultaneously treat, and so it behooves us to become experts in substance use disorders if we're mental health clinicians. Just as I believe that substance use disorder clinicians, it behooves them to learn mental health treatment, because there's like an 80% overlap between the two sets of disorders. And how could you separate them out anyway? We often use substances. One often uses substances to self-medicate mood disorder, mood lability, and emotional lability, depressive disorders, anxiety disorders, psychotic disorders. And do we hold off on, saying to somebody who comes into a substance use disorder clinic, let's have you get off your heroin, and oh, by the way, we're not going to touch your cigarette smoking, your 2-pack-a-day cigarette smoking, and by the way, your hypertension and congestive heart failure that's emerging over time, that's going to shorten your life by a couple decades. Let's not address that because it's all about your heroin use. No, it's about lifestyle and everything. So take it on. Use nicotine replacement. Use 12-step community supports with the cigarette smoking, and work on quality of life, balance of life issues that involve giving up cigarette smoking. Don't substitute one crutch for another. That sort of ducks the whole business, doesn't it? Anyway, that's my personal opinion. Other people will fight back against that and say, my God, their heroin use is killing them. Their cigarettes are killing them, but not for 30 years. Leave them alone. And I guess I'm more of a purist. All right. In your references, see if I can find that section for you, just to highlight it. Oh, here it is. You don't need to look at it. It's not going to be tested. Our treatment guidelines, some of which I have written myself, for medications. And they're just medication guidelines in terms of the names of medications, their brand name, their generic name, their indications, diagnoses that they're used for, their daily dosage ranges, blood levels if they're indicated, and their cost. And this is on section 4, starting at page 102 and going on through 108, both for, I think, for children and adolescents and for adults too. Or did I give you the, no, I think I gave you the children and adolescent one in that course back in the fall. Nope, here's the children's in there too. It's page 110 and 111 and 112. These are very helpful, quick and dirty guidelines. They're not clinical algorithms per se. They're just medication guidelines on dosages when you're over the limit. And if you need to go over the limit, by all means, just document why. It's which reference section? It's section 4, and it starts at about 110 for the medications. Or 108, something like that. Actually, it's 102. 4-102. All right. These You can look at these sheets very quickly. You can spell the medication correctly. You can often put it in generics because generics are where it's at these days in terms of price, although there's a whole bugaboo about that we won't get into, where the pharmaceutical company will buy a generic company and then deep six its generics so you can only sell the brand name. That's a pretty nasty way of operating, but it's makes more profit. But I recommend these guidelines to you, medication guidelines, to just make sure you're in the ballpark or that the patient is in the ballpark. If they're being prescribed, let me just pick one. Let's pick Xanax. I'm going to find that in the list. It's on page 107, I believe. Xanax, I'll praise the Lamb. Daily dosage range up to 10 milligrams. If you have a patient who comes in saying, Doc, I'm prescribed 20 milligrams a day of Xanax, one, it might not be true. Two, they might be getting it off the street and have developed a high tolerance to it. And three, it's quite alarming because if you in your wisdom were to take them off it altogether cold turkey, they'd be liable to have a seizure, withdrawal seizure, and perhaps even status epilepticus, and perhaps even die as a result of that. So somebody comes in and they tell you that they are taking 20 milligrams a day of Xanax, that's a red flag, right? And something that you ought to be concerned about up front. If they truly are taking 20 milligrams, they probably need they need some sort of taper, but they shouldn't be taken off at cold turkey. And they should be withdrawn. Now, the American way, the good old fashioned, or the good pull them up by the bootstraps, conquer the West way of doing it is to decrease by 10% a day or every 2 days till you're off it, which is 10 to 20 days, or more reasonably, the British system of 10% a week for 10 to 20 weeks, or the way I've done it with several patients, especially older patients, is about 10% a month over many, many months to do it. And I think I mentioned to you one case that I had of a man in his 80s who was on Xanax, and he was on like 6 to 8 milligrams a day, and it took 18 months to taper him off it successfully. He was highly motivated, and but it took that long to help him reequilibrate, if you will, his physiology to adjust to the lower doses. If I went any faster than every 3 to 4 weeks, it was overwhelming to him. And we had to go back. All right. Folks, we ought to take a break. It's about 6 minutes before the hour. Let's meet at 4 minutes after 2 p.m., which will be a 10-minute break from now. All right. Talk to you in 10. Okay, ladies and gentlemen, let's continue. This is the second to the last hour before we end the course. For the next hour or so, we're going to look at medication education sheets and look at resources and look at consents. And that's going to head us into the whole patient's rights discussion. All right, so I'm on slide I was on slide 80, now I'm on slide 81, or I was on 82. Okay. Some more words about medication formularies. That these were originally developed by hospitals and insurance companies and Medicare, including and Medicaid, TennCare in Tennessee, Medi-Cal in California. They helped develop, or it helped them develop their appeal procedures, treatment authorization requests are involved in this process to get approval for specific medications that might not be on the first tier of the medication formulary, etc. We're next moving to slide 82. And we'll discuss patients' rights as it relates to medication consents later. But you have in your reference section, this is starting section 5, and it goes on for 47 pages under section 5. Pharmacologic or psychopharmacologic medication education and informed consents. And there are probably 20 different medications listed and consents for each one. Now, the consents may be general consent for just psychotropic medication, and you write some of the specifics down. And there are also different categories of consents, such as consents for anti-anxiety or sleeping medication, and with check boxes of which benzo in this case or antihistamine might be used. These were developed, I stole these from hospital settings over the years and took out identifying, information for the hospital, etc. And these are often 2-pagers, meaning both sides of one page, with the first side being the medication, just like we did when we looked at the paper medical record for patient John Doe and his anti-anxiety medication, what was it, Ativan, and his antidepressant medication, Effexor, if I remember right. So there are check boxes at the beginning of each medication consent. Is it going to be for the anti-anxiety medications? Is it going to be Xanax, Librium, Klonopin? Is it going to be the antidepressant Trazodone? Is it Valium? Is it Benadryl? Is it Vistaril? Is it Ativan? Is it Serax, etc.? And so you check which one, and then it says, I give my consent to take this medication at the for the above dosage maximum, number of times daily, route of ingestion, whether it's orally, PO, or IM, or both, maybe. The patient signature, a witness signature, the physician signature, or the prescriber signature, and also a whole section for withdrawing their consent. I don't want to do this anymore. It was a mistake. I changed my mind, and the medication can be withdrawn immediately and discontinued. On the second page or back page of every one of these medication consent sheets are the advantages to taking the medications, the alternatives, what would be non-prescribing alternatives to these medications, what would happen if you went without the medication, what might happen, possibilities, and what are the side effects of the medication, and what happens in overdose, and what cautions need to be exercised specifically to these medications. In the olden days, that is before about 15, 20 years ago, these were all very separate and individualized, and there was no check boxes or anything way back when. You just individualized everything. And now we do it in a little bit more efficient and intelligent manner. Which page number, the reference? I'm looking at 5-4 for, oh, that's the antipsychotic one. 5-2 is the reference section 5, -2 is the anti-anxiety medication consent sheet, the one we looked at for the medical record for patient John Doe this morning. Okay, so when you, when I had a high outpatient practice, I had folders and files for these in my file cabinets. Whenever I'd prescribe a medication, I'd pull out a consent form that had an education part attached to it, and I'd have the patient sign it. I think it's good for medical legal purposes, for patient education purposes, and to keep you honest. Remember, you're only doing this with the consent of the patient, and you need, in my opinion, more than just their verbal consent, and hospitals require it. But I do think outpatient practices need to do this also to cover your base. God forbid that something untoward would happen and you would be sued for medical malpractice, and the patient said, I never consented to this, or I was never educated about this. No, here's your signature, here's a witness, etc. And there should be no surprises in this regard. By the way, it's a sheet of paper that they take home with them to remind them or reference if they should have side effects. Look at this sheet, see if you're having side effects based on this information provided, and give me a call or come in your next session and let's talk about it. But educate yourself a little bit about it. I encourage you to go on the web, I'm saying to a patient, to learn more about this medication. You might see some, if you found the CCHR, the Citizens Commission on Human Rights website that says that all psychiatrists are murderers and rapists. I don't necessarily bring that up at the beginning, but I do say that, you will find things on the web. There's anything for anybody on the internet, and be careful about who the source is. Be wise and careful about it. This is particularly important, as I've emphasized before, when you're prescribing off-label or higher dosages, perhaps, or for age patients that are not FDA approved for that medication. It's important to alert the parent, particularly to that you may find something on the web that says this is not prescribed for children, but here's how it is, and here's why it is, and here's the evidence for it, etc. All right. So in your reference packet of about 40 pages, give or take, You have consent sheets on anti-anxiety medications, antipsychotic medications, lithium, anti-manic medication, other anti-manic medications, the mood stabilizer, anti-epilepsy medications, um, stimulant medication, even clonidine, prescribed off-label for ADHD. There are medication consents for individual medications such as Celexa, Paxil, Neurontin, gabapentin. We talked about that a little bit before with that patient. Not a big fan of Neurontin, gabapentin. And some of these consent sheets I designed, and some are from the pharmaceutical companies. They have great education sheets, believe it or not, on their medications. They want the consumer to be aware, etc. And there are even sheets on monoamine oxidase inhibitor special diets, and things of that nature. So a lot of practical information in this reference material that would be good patient education, not to mention education for us and refreshers for us. Yeah, there we go. All right. Now let's shift gears and talk. I mentioned about the Celexa, the Paxil, the Neurontin. There's also medication sheets on all these medications listed on slide 84. And the atypical antipsychotics, even antabuse used for alcohol dependence and causing a antabuse reaction when you drink. Okay, let's shift to slide 85 and talk about resources. I mentioned before the break that I frequently go on the internet in looking up medications, how they're spelled, how much they cost, what is being said about them, even lay chat rooms and what people are saying about them. I think this is very interesting, and I like to see the lay of the land when I'm prescribing. What is the buzz on this medication? There is a wealth of material on the internet, both good and bad, and you have to be skeptical. There are biases like Scientology, etc. In the olden days, we would get everything, this is before the internet, we would get everything from medical libraries and lay libraries. And I would often put in queries to the medical librarian, who was my right-hand person and they loved it. They were wonderful people, and they just loved their job, and they were like auxiliary doctors, if you will, in providing information and coming up with the latest research. And I would often spend a half hour, an hour every couple of days in the medical library in the afternoon, looking up articles or talking to the librarian who had pulled some articles from me from the day before, et cetera, and we'd be talking over things, and it was incredible. Can't remember the specific woman's name at St. Mary's Hospital's library. Eleanor, that was her first name. Eleanor Benalisha, that's who it was, yeah. And she was, we would invite her to parties, to staff parties and stuff, because she was part of the team, the medical librarian. She was our internet, and she was a great detective and very valuable to us. Okay. Also, local pharmacists can be quite helpful. And you can call a pharmacy. These days it's getting harder because they're so put to work so much I got a flu shot about a year ago, and I just in passing said, "What's it like being a pharmacist these days?" And this kind of youngish pharmacist in his late 30s said, "It really sucks." And I said, "Tell me more." He said, "More work, less pay, less autonomy, um, higher volume, and a lot of job dissatisfaction." And I thought, oh gosh, this sounds awful. Um, at the same time, he was a bright, nice guy and interested. He was interested that I was a semi-retired psychiatrist, and we had stories to talk about in the brief time that he was doing the flu shot for me. Um, and a good guy, but a tough work for pharmacists, and yet they are professionals, um, and they're quite rigorous, and they are the kind of the final logical step before disaster with regard to a medication, if it's the wrong dosage, wrong medication, etc. And they are now required by many state legislatures to provide patient education, and that's why they torture you a little bit when they say, "Can I have you?" The pharmacy tech says, "Can I have you wait and talk to the pharmacist so that they can answer any question you have about this new medication?" And it's like, I don't have time. But that's what they're there for. That's what they're trained to do. That's what they're required to do by increasing tightness in state legislatures around pharmacy. And they're the ones that will give you patient education, um, but don't use it as an excuse not to provide your own education when you're prescribing or part of a team that's prescribing. Don't use it as a fallback to, oh, the pharmacy is going to tell them everything they need to know. I don't have to say anything about this. Well, that's bad patient, in my opinion, that's bad patient rapport and therapeutic alliance, and also turfing, and not a good idea. So I recommend against that. Also, pharmaceutical companies can be quite helpful. Uh, they have entire departments set up for this patient education, and they will also help with the cost of medication and copays. They almost all have programs for so-called indigent patients. One of my nieces who took an antidepressant, I said, go call up um, uh, Pfizer that prescribed the antidepressant, I can't remember which one now, and see if they'll provide the medication for you at no cost as part of a patient assistance program. And indeed they would. All she had to do was contact them. And at Kaiser, as Janelle says, you cannot receive a new prescription without patient education from the pharmacist. So they're really pushing it. And it's good information, it's solid information, and well worth it. And take advantage of it, but don't use it as an excuse not to do your own patient education, is, I guess, my point. Pharmaceutical companies have a lot of information on their websites about their medications, even the scientific studies that back up the use of their medication, etc. And they can be helpful with that. Other resources, slide 86, the internet, incredibly helpful. I will go on, if I'm unfamiliar or don't fully recall everything about a medication, I will go on a website. Often I go to rxlist.com. I like that. I know it well. You can cut to the chase, get dosages, blood levels, things like that. And WebMD and SafeMedication.com also are good. And there's a number of others. It keeps evolving and changing. So don't hesitate to Google a medication and just see what you can come up with around that. All right. Patients' rights. Now, a whole new section. Um, Patients' rights and consent for medication. We're also going to get into patients' rights to refuse medication, right? Okay. Do you remember 6 months ago when we did the child and adolescent course that I taught you that theoretically informed consent means equal bargaining partners, both having similar information? Ideally, the consumer knows as much as the prescriber. Well, that isn't reality, but that's an ideal to aim toward. You would never expect to have such informed consent for your appendectomy that you understood every detail and nuance, every tissue layer, muscle layer in the abdomen that the surgeon had to cut through in order to get to your appendix, your inflamed appendix. You didn't go to medical school and become a surgeon to have an appendectomy. You rely on the skill and professionalism of the surgeon. But the goal and the ideal is of true informed consent is that you know as much as they know in and helping you make your decision. And I can't help myself. Maybe it's late on Sunday afternoon, but I have to tell you a quick little story about a surgeon who took out his own appendix for appendicitis. And I just found this the most bizarre story. It's true. I was visiting the wonderful country of Belize, the old British Honduras, and befriended a expatriate, an American from Florida, a woman in her 70s, who told me the following story about her brother, the surgeon, and his self-done appendectomy. The brother was an expatriate also, living in, I believe, Costa Rica or El Salvador. I can't remember now, one of the Central American countries. He was living alone. He was married to a local, and he was a retired surgeon. And he was out in the middle of nowhere, inadequate medical, capacity, no local hospital around, and he had a case of acute appendicitis. He self-diagnosed it, and he prepared his wife and their servant to be assistants on his own surgery, and he got himself sufficiently drunk to dull the pain as he and they cut into his abdomen through those many different layers. I think there are 9 layers, if I'm not mistaken, through your abdominal wall, through the muscle, the fascia, etc., the skin, etc., to get to the appendix. And he and his wife and assistant, the servant, did a successful appendectomy. And I remember that story. I heard it about 10 years ago, and I'm still in awe of, I'd like to meet this guy. Talk about chutzpah, right? Well, he truly had informed consent. I guess that's the punchline of this. I hadn't thought of this way, but he truly had equal bargaining partners with the surgeon because he was the patient and the surgeon. All right. So we talked about special populations when we talked about children and adolescents, and I mentioned to you the children that I described in some detail and their level of understanding and how much consent you do with them, how much education you do with them. With the younger kids in the elementary school ages, especially the younger elementary school kids like this 5 and 6 and 7 year olds and 8 year olds, you might talk about helping them do better in school. And this medicine for your ADHD will help you not get in as many fights and things like that. With the teenagers, it's a bit of that with getting along with others and doing your best work in school and not being as sad as you've been or as hyper as you've been, etc. Um, and there was so what about a elderly person who perhaps isn't focused on it, doesn't want to know the details? Doc, you're the doc. I'm just the patient. You do what's going on. You do what's right. You often educate the adult child of their adult children, and to look for different side effects and to watch out for them. They may be overly tired. It may increase their appetite. It may make them hyper. It may make them sedated. You want to warn a family member or a caregiver, etc. What about incompetent people or people experiencing mental health emergencies? So I had this patient in San Francisco General Hospital, the new Zuckerman Hospital, named after the Facebook guy, at Psych Emergency, who was high on PCP and was literally diving out a window that he broke by diving into it, sort of a transom window. So he had to leap up into it and then get caught halfway with shards of glass stabbing at his abdomen, and us pulling him back, us cutting ourselves in the glass, and him thrashing about and the rest. What kind of informed consent do you think he got? Nah, not much at all. This was an emergency situation. He was, quote, out of his mind, and he needed immediate chemical restraint, not to mention physical restraint, for safety reasons for himself and people around him. And for him, we alternated, and this is my cocktail that I recommend for such emergencies, is a chemical cocktail of Haldol 5 milligrams alternating with Ativan, the benzodiazepine, lorazepam, 1 milligram every 1 to 2 hours until asleep. So for him, it was every half hour, one or the other. I think he got 5 milligrams of Haldol, was put in, that softened him up a little bit to get him out of the window and the blood, put him in leather restraints, patch him up as best we could with bandages to stop the bleeding, patch ourselves up as best we could, and then in a half hour, a milligram of Ativan. These were IM at the beginning because he would refuse all medications. And toward the end of this, we would coax him into taking it orally as he was semi-sedated, but still out of touch with reality and overwhelmed by the PCP psychosis he was in. So Haldol alternating with Ativan until calm for the acutely dangerous patient. It really works. All right. Is your cocktail list in the references? It's not in the list listed as a cocktail, but Haldol and Ativan are certainly listed in the references. This is my own Dr. Brady's cocktail for psychiatric emergency, but everybody's got, if not that one, a similar one: Librium, Klonopin. I think Haldol is one of the best antipsychotics for this. I have tried using some of the atypical antipsychotics such as Abilify, etc., but they're not strong enough in a psychiatric emergency where there's psychotic agitation and you need sort of elephant guns to get them sedated. Okay. So what about, so we talked about mentally incompetent adults, the psych emergency one. We talked about children and adolescents. Patients on legal holds, we're going to talk about in some detail in the next hour and a half. How do you deal with someone who's on a mental health hold? Do you have to get consents to medicate them? The quick answer is yes, unless it's a emergency of life and limb. And how about patients charged with criminal acts and are in jails, etc.? How do they deal with those patients? Those are considered psychiatric emergencies, and they will medicate them without consent. Take this, I insist, you either take it orally or we're going to give you a shot, or they just give them a shot and they dispense with that. And we talked about patients with mental health emergencies. Okay. So now let's head into patients' rights in this discussion. It all started with the Nuremberg trials after World War II, where the Nazis were brought on trial for their experimentation and torture of prisoners, particularly Jews, in concentration camps for their war atrocities. And a number of these Nazis, former Nazis, were hanged as their sentence for these war crimes. So it was the Nuremberg Code that as an outgrowth of the war crimes trials of 1946 that was the first internationally recognized code for human research. It sounds amazing to me, even when I talk about it today, that was just over 70 years ago that we started talking about human rights, or people's rights in being forced into research against their will, and taking away their rights in that regard. So before the Nuremberg Code, and before a recognition that humans had rights with regard to their bodies and research on their bodies and being forced to do things against their will, there were simply physicians who were investigators and researchers and research institutes, and they independently and autonomously determined what was dangerous and what wasn't, and what patients should be informed about and what they shouldn't be informed about. It was a catch as catch can, informal system that had no real checks and balances, and brought about some pretty scandalous actions over the decades. So it was a convention at Helsinki, the Declaration of Helsinki, that really conceptualized and reinforced the idea of human clinical research required consents and education for the patients before they would agree to it. It was in the 1950s that hospitals began having ethics committees and boards, and the initiation of ethics committees in hospitals to determine what surgeries could be performed. And it didn't have to do so much with consents as it did with what surgeries were allowed and what medications were allowed, but it had less to do with patient consent, just what was allowed. Then there was the old U.S. Department of Health, Education, and Welfare, HEW, that has since been broken off into Department of Health and Human Services and Department of Education. And they started looking at the topic in response to reported abuses of the rights of individuals participating in certain federally funded research endeavors. And they began mandating that protocols be screened by institutional committees responsible for the protection of human subjects. And this, in the bad old days, we had the B movies in the 1940s and 50s, Snake Pit and others, private sanitariums. Remember those kind of movies where the wife would often be taken off? The husband, the dissatisfied husband would call up the doctor, the family doctor, and the wife would be picked up at night against her will and taken to a sanitarium and drugged up. And that was legal and ethical and not a problem in the 40s and 50s. And it made great film noir movies, B movies, way back when. All right. Moving on to slide 89. It wasn't until 1974 that we had a national commission on the protection of human subjects of biomedical and behavioral research, which when I think about it, it just seems so short ago, relatively speaking. This was established by Congress. It was a congressional act. And out of this congressional act, they issued the Belmont Report of 1978. And I'd like you to remember the Belmont Report because it was the Belmont Report that first coined the term informed consent. Before that time, there was not a uniform language to define what we're talking about with patient consents. So informed consent came from the Belmont Report, which is a congressional action in 1974. So that was the beginnings of the new era of true informed consent for patients. And it really, the Belmont Report said, hey, you have to look at the risks and benefits of that research. And you have to select patients and subjects who are competent to make consent. You can't just swoop in people. You can't just take retarded people, etc. You have to have true informed consent, or the beginnings of it at any rate. All right. So now we have the right to refuse treatment, because before informed consent, it was not very relevant. Now, let me back up a little bit. Voluntary patients have always had the right throughout time to reject a treatment plan or a medication, except in emergencies when danger to self or others. Voluntary patients. We're not talking about voluntary patients. We're talking about involuntary patients that are committed. And this controversy arose between what their perceived patients' rights were and their perceived patients' needs were. And until the late 60s, if you needed treatment, that was a criterion for involuntary commitment. Well, who made that judgment? That's the critical factor. Who's the agent in this? Was it the spouse? Was it the doctor? Etc. So these things now get nuanced. So it wasn't until the 1970s that the criteria for involuntary commitment shifted away from the need for treatment towards a dangerousness standard, separate from a need for treatment. So here's the thing. Antipsychotic medications work, right? They work in spite of protests. And in the old way of thinking about it, it made no sense to admit a patient for treatment and then allow them to refuse to take the treatment, the antipsychotic medication, right? It just didn't, it wasn't logical in a simple world. It would, what this in effect did is it turned hospitals into gulags. It turned hospitals into prisons and doctors into jailers, because what it said is once you're admitted against your will, all bets are off. We can do whatever we want because you need it, because we decided that you need it. We're the big brothers and we decide, we the psychiatrists. But in this new era of patients' rights that comes out of the civil rights era, by the way, first it was the civil rights struggle of the 1960s, and then when that got settled to the degree that it did, Martin Luther King, the Great Society, blah, 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 desegregation of schools, separate but equal was done away with. The movement started then towards patients and patients' rights. So it was an outgrowth of the civil rights struggle. The right to refuse treatment for a mental patient. So in this new era of patients' rights, the law came to recognize that patients were not incompetent even when they were committed. Okay, they were committed because they were dangerous. Danger to self, danger to others, gravely disabled. That did not make them incompetent. It simply meant that they were dangerous and needed to be locked away. They were competent for other purposes. They still could marry. They could enter into contracts, even if they were in a hospital against their will. So it was just logical that giving informed consent to medication was the next step in this. They were competent until proven otherwise. And this was the major shift in the 1970s. So civil rights attorneys shifted their focus from the civil rights struggles to patients' rights struggles. And it was the same attorneys, the same federal judges and attorneys that got involved in this. So I had the rare privilege in the late 1980s to visit some friends in New York City and have dinner with one of these old civil rights attorneys who was in his 70s at the time. His name was Marty Garbus, G-A-R-B-U-S. He was a 1960s civil rights attorney that took on the first case for mental health, right to refuse treatment in the United States. And it was Bryce Hospital in Tuscaloosa, Alabama, where I went to medical school. And he sued the hospital. And I'll tell you about that case. Okay. So here's a little question for you, ungraded, of course. Patient's legal right to refuse psychopharmacological treatment is an outgrowth of the U.S. civil rights movement of the 1960s. True or false? Well, I handed it to you, folks. It's definitely true. It's kind of cool. It's kind of an exciting historical phenomenon, if you're into that. All right. So what was that case? It was Wyatt versus Stickney. In Tuscaloosa, Alabama, 1970, Ricky Wyatt was a patient. Dr. Stickney was the medical director of Bryce Hospital in Tuscaloosa, Alabama, which was the huge state mental hospital. And Marty Garbus took before federal judge Frank Johnson, who was a civil rights attorney in many of the civil rights struggles in Alabama and the Deep South in the 60s, and brought this case on, and they won against Bryce Hospital. This lawsuit was based on the right to refuse treatment, that it violated the 8th Amendment ban, the constitutional Eighth Amendment ban on cruel and unusual punishment. Now, how did this whole case arise in the first place? It was the weirdest thing. Um, at that time, Alabama funded its state mental hospital with hundreds and hundreds of locked away patients, sort of warehoused, through the state cigarette tax. And in its wisdom, the Alabama legislature said, our cigarette tax is too high. We need to lower it down. Our cigarette consumers are suffering. We need to lessen their burden for paying for cigarettes. So we're going to cut the cigarette tax significantly. What that did is it cut the funding for the state mental hospital significantly, and they could no longer afford all these patients. So in a way, they were, Alabama was sort of willing to throw to to go along in some way to allow this lawsuit. They didn't, it's not that they allowed it, but that they weren't too unhappy with this lawsuit and having it be declared unconstitutional, because then they could clear out the mental hospital and not have to, you know, and get along with the lower cigarette tax. It's kind of cynical, but there it is. Now, let me describe the care in those mental hospitals at the time in Bryce Hospital. They would segregate men and women into different wards. For the weekly hygiene, they would put all the men in a shower room and turn a fire hose on them naked. And they did the same for the women once a week. They gave them substandard food. They overloaded them with antipsychotic medications that were becoming more and more popular in the 50s and 60s, Miloril and Thorazine. They would warehouse them, and they would never discharge them. They would never treat them. They never had individualized treatment plans. Once you check in, it's like a roach motel. Once you check in, you don't check out. And they also did a lot of psychosurgeries with lobotomies, ECT. One of my medical school friends in Alabama had electroconvulsive therapy in the 1970s because she told her parents that she was a lesbian. And that automatically brought her, by the fundamentalist parents, to a psychiatrist who then gave her ECT to treat her out of her lesbianism. It didn't work, by the way. And she was very bitter about it. But this just happened left and right, without consent, without consultation of counsel, etc. And Wyatt versus Stickney knocked all this out. So one of the things that Wyatt versus Stickney said is that you must have least restrictive conditions. You can't just warehouse people. You can't force them to take medications just to quiet them down. You can't do experimental research on them. You can't subject them to lobotomies and ECT without consent, consultation with their counsel. And they have to be released if you're not doing anything. If you don't have a treatment plan and you're not treating them, you have to release them. Well, that was the beginnings of releasing all these nationwide patients into the communities without the support of community mental health centers. And that was its own tragedy. And yet we ended a different kind of tragedy before that of warehousing. Quite a whole system. Okay, ladies and gentlemen, let's take a 10-minute break, our final break of the day. We'll get together again at 3:04 p.m. Pacific time in 10 minutes. Okay, ladies and gentlemen, let's do our final hour of the weekend course on ethics and legal issues in psychopharmacology. Are we ready for our final hour? All right. Okay, and Mateo said attendance question mark. Is that a thought for you, Aiden? Do we need to do a final attendance or did we already do one? I can't recall.
With your permission, I'm gonna give like few minutes so that I'm sure everyone is.
Oh, people will come
on
back,
the,
sure.
Yeah.
Okay, at the right time, just jump in.
Sure.
And go ahead and do that, Aiden. Thank you.
Sure.
All right. So we just talked about Wyatt versus Stickney, and the first U.S. case having to do with the right to refuse treatment, the freedom, the least restrictive conditions, the freedom from unnecessary experimentation or excessive medication, the right not to be subjected to psychosurgery or ECT without consent, none of which had been done before, remarkably. All right. So, ladies and gentlemen, this is another lob question. Which amendment to the U.S. Constitution is relevant to the right to refuse mental health treatment? Is it the First Amendment, freedom of speech? Is it the right to not self-incriminate? No, it's the Eighth Amendment. You all have it. It prohibits cruel and unusual punishment. That was the basis of the mental health patients' rights struggles. All right. Okay, moving on to another case, and this is 1973. Remember, Wyatt versus Stickney was 1970. Okay, and this one is Knecht versus Gilman. And just one sec. Yeah, that's fine. Okay, so this was a prisoner. So Jason said this is an interesting legal idea because the Constitution only prohibits government from engaging in cruel and unusual punishment. And what do I think about the use of ECT today? I'm happy to share my thoughts about that. Yeah, it is an interesting legal idea, and it was a new avenue, if you will, to say that it's cruel and unusual punishment. And the way they attached it is that the state hospitals were acting as a agency of the government. And that's how they attacked it. These people had no rights. They were forced by their government into these state hospitals and forced into these inhumane treatments and lobotomies and ECT, et cetera. And that's how they made sense out of it. Yeah. What do I think of ECT today? It's a great question, and we don't have a ton of time to talk about it, but I'll share my quick and dirty thoughts. I have seen some remarkable recoveries from severe depression and psychotic depression with ECT over time, over 30 plus year practice. I have never performed ECT myself. Oh, that it was a state hospital. Yeah. Yeah. Bryce Hospital was a state hospital, part of the government of Alabama. I've never done ECT myself. I haven't wanted to. I've referred patients of mine to specialized psychiatrists who do ECT. If you want ECT done, you really ought, just like a surgeon who does 5 appendectomies a day, you kind of want to go to a specialized psychiatrist who does ECT every week, every day. because it can be complex and dangerous. And they have refined it now with, and I don't remember the name of the medications anymore, of the paralyzing drugs, but they actually put a tiny tourniquet around your baby toe, so that it cuts off circulation, so to speak. And when you start seeing the patient seize only through that baby toe moving, because it didn't have the circulation and the paralyzing agent, did they know that they've done an effective seizure beyond the electroencephalogram that is done simultaneously and concurrently. They use lower voltage. They use it unipolar versus bipolar, or both hemispheres. And they use it for shorter durations. What they have found is that they've refined it such that the memory loss that you can get, the short-term memory loss, etc., is much better than it used to be. It used to be much more heavy-handed. Patients would break bones, break ribs, crack teeth, etc., and that just doesn't happen anymore. So my last patient that I referred for ECT, this was 20 years ago, was a society matron in San Francisco who literally had ladies at lunch parties that she would host at her house, and she would insist on having her ECT in the morning at 8 a.m. first thing, so she could be home and help the caterers set up for the afternoon, for the luncheons. That's how smooth it went for her. So Mark says that he's seen significant improvement in patients who've had vegetative depression, not responsive to other medications. And several treatment-resistant patients, Joy says, that have responded very well to ECT. So it really is a lifesaver, so to speak, in some respects for treatment-resistant depression. It can be done quite safely as an outpatient procedure, and minimal residual memory deficits. But I wouldn't do it unless it failed, unless they failed 2 or 3 different families of antidepressants, a good course of psychotherapy and family therapy and couples therapy, etc., and tried everything. It worked beautifully for my patient who had a psychotic depression. At one point, she was convinced that she was radioactive to her family and causing radiation sickness with her adult children and her husband, who was prominent in society in San Francisco. And I even borrowed a Geiger counter from the radiology department to, quote, prove to her that she was not herself radioactive. And her response in her psychotic depression was, it must have been the fault of the machine not to pick up her radiation. That was her rationale for it not working for her. I thought it was pretty clever on my part. Who administers it? It's done in hospital settings as an outpatient by specialized psychiatrists, and along with the help of an anesthesiologist, etc., putting them into a light sedation, but so that they're totally unaware of what's going on. And then there's what I call ECT light, which is transcranial magnetic resonance, TMR. And that is a football helmet type device that's put on your head, and magnetic waves bombard the brain and don't cause a full-blown seizure, but activate the brain in a way similar to ECT. Why does it work? We don't know. It seems to flood the brain with neurotransmitters, and over time that can be helpful. It was a lifesaver for this particular patient, and she went on, after a course of about several months of ECT, weekly ECT, maybe 10 treatments, to have a normal functioning and normal life after that. She never admitted to the psychosis part of it and the radiation part of it, but hey, um, that's okay. She didn't need to. And I always remember her because she was quite dismissive of me, because I was middle class or upper middle class, and she was upper class, and she kind of had no use for me because I wasn't in her social class. Um, so Mark says at Montefiore in the Bronx, so I trained as a psychology intern, some ECT treatments, medications they use 30 years. It's succinylcholine, that's right, and atropine, I think. Propofol is used, yeah, to not to reduce seizures, but to anesthetize them so that they need a seizure. That's the whole point of it. But to reduce to anesthetize them from the bad effects of the seizure, such as broken bones, etc. Okay. So getting back to Neck versus Gilman in the 1973 case, this was a very interesting case. It was a criminally insane guy who was transferred to a mental hospital, and in that hospital, they gave aversive stimuli, apomorphine, which causes vomiting for minutes, and it was a behavior technique when they didn't want you to be swearing or violating rules of the prison, etc. And this was challenged as and the court ruled that you cannot force administration of medications because someone is swearing or misbehaving. That's called torture and punishment, and you can't do it. All right, this is a nice little quote from 1914 from U.S. Supreme Court Justice Benjamin Cardozo, quite a famous quote in the forensic mental health literature, that every human being of adult years and sound mind has a right to determine what shall be done with his own body. And this was the case of Schlondorf and Society of New York Hospital, a Supreme Court case in 1914. Society at that time was becoming particularly sensitive to the possibility of mind control by psychiatry, and this was a court that went to the New York Court of Appeals and then on to the U.S. Supreme Court. It made me think of two things, just to say as a quick aside. You remember a number of years ago during the Second Gulf War, when Saddam Hussein was deposed, that there was this controversy among with the CIA and two psychologists, clinical psychologists, who advocated waterboarding, enhanced interrogation techniques that other people said, let's call it what it is, it's torture. And these two psychologists were sanctioned by the American Psychological Association and in court themselves for advocating waterboarding and other, quote, enhanced interrogation techniques. Yeah, there was a movie about it. There's one on Netflix about the having to do with the U.S. Senate recently. That's quite enveloping, quite engrossing, and quite good, worth watching. These two psychologists still advocate for their position and say that they didn't do anything wrong, by the way. It also brings to mind for me, thinking of upcoming U.S. Supreme Court taking on Roe versus Wade and the competing rights of the woman and the fetus. They're going to have to weigh the competing rights of the pregnant woman versus her fetus. And there is high likelihood or reasonable likelihood with this new conservative court that Roe versus Wade, after 35 years or so, will be done away with, and abortion will be declared illegal in the United States, and it will go back to the states. Some states will allow abortion, and other states will prohibit it. It's where we're headed in our Supreme Court. But it brings to mind Judge Cardozo's comment that people have the right to determine what's done with their own body. Okay. Stay tuned.
Doctor,
That one. Yes.
if it's okay, at this point, I just run the attendance.
Please. Okay, I'm going to keep moving. We have about 40 minutes left till the end of the weekend, and I want to make sure we get through this material, which I think we'll be fine with. The next slide is slide number 98, and continuing on some of the court decisions of the right to refuse psychopharmacologic medication. So now we're going to talk about the vicarious decision makers and the different models. So there are essentially 3 different models. One is the best interest. What would be in the best interest of the patient? And so New York courts in 1986 did their case, Rivers versus Katz, and came up with the idea that the patient's best interest is what's most important. Another one is called, it's subtle but different, subtly different, is substituted judgment. What would the patient want if they were competent to make a decision? If they were their best selves, what would they choose? And then the third is the doctor makes a decision. Maybe a second doctor, so that you're not having your biased doctor who's wanting to, medicate. You'd have a second doctor who would make a so-called independent decision, and that would be Rennie versus Klein. The substituted judgment case was Rogers versus Commissioner, and you can see the dates. These all took place in the 70s and 80s. So Rogers versus Commissioner, the second one, was a so-called rights-driven model. What would the patient want? What would they choose? And the Rennie versus Klein was a treatment-driven model. What would the doctors say, right? So here's a lob question for you. Regarding patients' rights to refuse medication, Rogers versus Commissioner, Massachusetts, 1983, is a treatment-driven model, where Rennie versus Klein, New Jersey, 1979, is a rights-driven model. True or false? And the answer is B. I just gave you the answer earlier. It's the opposite, right? So these are different courts deciding their own precedent, if you will, for these states, New Jersey and New York, New Jersey and Massachusetts, of a patient's rights versus a treatment-driven model determined by the treaters, the doctors. All right. So here's another one. where the judge makes a decision. It's not the second doctor. It's not the patient. If the patient were competent, it's the judge makes a decision. And this was adopted in 1977. It's Belchertown Hospital versus Mr. Sikowitz. Mr. Sikowitz was a profoundly retarded man with leukemia, and the question was, could he be given chemotherapy against his will because he didn't understand, he was profoundly retarded. And it was the judge who made the decision. And this is a case that set precedent for Massachusetts, Oklahoma, New York, Colorado, and Wisconsin. So if you are in one of those states and you want to refuse medication, the judge will make the decision finally. And then there is the so-called Utah model, where the psychiatrist makes a decision. This is sort of like the second opinion psychiatrist. This is a case in 1981 with A.E. and R.R. These are two brothers, apparently, versus Mitchell, who's the medical director. And Utah now requires, and this is a decision changed in 2016, where a medication review committee makes a decision, and the hospital clinical director makes the final appeal decision. So it's a bit of a hybrid where the not the judge, not the doctor in this case, but the clinical director makes a decision. So each case is different. Each case sets precedent for the states and some states around it. And Utah decided that the due process allows a state hospital to forcefully medicate a patient who's found to be incompetent if it's thought to be in the best interest of the patient. Utah has always been a little bit conservative and behind the curve. Utah was the one that in the olden days, a husband could call and have one of his wives, I don't want to be pejorative here, but there it is, sent off to a state hospital against her will and medicated against her will. Okay. Finishing up this discussion is the on vicarious decision makers is the U.S. Supreme Court decision in 1990 of Washington versus Harper, where an administrative layperson attached to the court makes the final decision. And this was so a deference to medical decision making. And it's interesting when you have administrators, court administrators, etc., decide, they often conservatively decide for the hospital against the patient. In other words, they more often than not decide for medicating. They err on the side of taking away the patient's rights. All right. So slide number 103. It's just some interesting little factoids about refusing medication. It may be kind of surprising to you to learn that only between 1 and 15% of involuntary patients refuse medication. You would think that a majority of involuntary patients might refuse medication, especially if they're paranoid and think you're out to get them and they're put into the hospital against their will and they don't like it. They often, I've had many a patient, an involuntary patient, say, well, you're the doc, you know best, and here I am locked away. I don't have any choice about it. Why are you asking me for permission? You decide. That's their rationale often. And I said, no, you can fight this. You could go to court. You know, we could have a a court hearing over this and you can be heard in court. No, doc, that would be a waste of time. I wouldn't win anyway. Who would listen to me? That sort of stuff happened all the time. Now, it is a fact that involuntary patients who refuse medication are more likely to be assaultive, more likely to require seclusion and restraints, have longer hospitalizations, and that was a study done a little more than 20 years ago. So it is worthwhile to take this to court, and if you believe in your prescribing opinion that someone should be medicated against their will, it behooves you to follow it up and take them to court and get approval for it, or try to in any case. So here's just a little factoid about California. And we talked about this in the child and adolescent case, but if you were ever asked a question of patients who are over age 14, they don't require parental consent for medication in California, the answer is no. They do, because the parent is in charge of them until age 18. So just because they are an adolescent, they still require the parent's consent, regardless of their feelings about it, of the kid's feelings about it. So here's another lob question for you. The vast majority of patients, including involuntary patients, accept psychotropic medication when offered. True or false? The answer is true. They say, "Doc, you're the boss," or, you know what's best, or, "Hey, I don't want to be here, but I do know I've got a problem, and I have faith that you're." So one little nuance in this whole discussion is it's incredibly important to do your very best in following the Hippocratic Oath, being ethical and doing no harm and doing good and establishing a therapeutic relationship with the patient, even if they are involuntary. The way I think of it in my head to make it more palatable is there is a part of them that is resisting treatment because their mental illness has them being paranoid, and perhaps they've had a lot of or some life experiences that justify their feelings of paranoia and being mistreated. But I'm doing my darndest to be honest and truthful and transparent and help them. And they're benefiting from that help, and they're acknowledging that help by agreeing with me. I have never shied away from treating involuntary patients. They're salt of the earth people just like everybody else, and they're just in a particularly bad spot in their lives, to say the least. Okay. So continuing on with the right to refuse medication, you may be interested to know that court reviews of refusals are overridden at least 90% of the time. That is, the courts tend to side with the prescribers and against the patients 9 out of 10 times. And what I find most interesting is that a lower percentage are, if you have a second opinion doctor, they tend to override treatment refusals, certainly more than 50% of the time, but 65 to 80% of the time. In other words, courts and court commissioners and judges tend to side with the treating prescriber more frequently than their own colleagues, which I find really interesting. There are no studies that suggest that large numbers of patients in need of medication are going untreated because they're right to refuse. In other words, it's not a huge problem. All right. So, slide 107. what to do if a patient refuses a judicial order compelling medications, refuses PO, refuses to cooperate, refuses to be involved. One of the things that happens is that it increases the costs of the hospitalization due to delay, due to the review process itself. It can add days onto the hospitalization. What do you do? So if a patient has a court order to take medication and they refuse it, how do you handle it? Very simply, you say, patient, you do this in a therapeutic, kind way, respectful, but you say, we can do this the easy way or the hard way. You can take this oral medication, which the court has ordered you to do, or you can take that medication by injection, your choice. Well, a ornery patient will often call you on it, and you'll have to give that first injection by IM, sometimes in restraints and sometimes with 4 staff holding the patient down. But I'll tell you what, people aren't stupid, and after the first injection, they'll then take it orally. And so often at the beginning, the nurse will come to the patient with some backup behind them saying, I brought you your medication. I'd like you to take it orally. It would be better for you, better for us, safer for the people on the unit. Please take it. No, screw you, fuck you, blah, blah, blah. Then I'll give you a minute or two to consider it and think about it, but it's going to happen, and it's going to happen by injection if you don't take it orally. And I've never seen a patient, well, that's not true. I remember a couple who just would never agree to take it orally, but the vast majority always took it immediately or after the first injection. So just another point that a lot of states through regulation now require giving informed consent information to patients. California, Pennsylvania, Texas, and others do require this. All right. So do California mental health patients have the right to refuse medication? The court case involved in this is Reese versus St. Mary's Hospital. This was a case, it was my hospital in 1987. I was there, I was just finishing my child fellowship. The patient's rights advocates found a patient. Her name was either Eleanor Reese or Elizabeth Reese, I can't quite remember now. And she was a in and out patient on a hold, always on a legal hold. And the hospital forced her to take medication, and they went to court all the way up to the California Court of Appeals, and they won the case. The patient's rights advocates won the case. And what it came down to is if an involuntary patient refuses medication and is not an emergency, this hospital staff must request an administrative judicial hearing to determine their competency and to file a petition with the Superior Court of California. They have a patient's rights advocate with them who is an attorney. And these people are really super, and they're dedicated and hardworking. I knew a number of them as, I wouldn't call them friends, but they were acquaintances, and I had a lot of respect for them, and I think they had respect for me too in what I did. And the judge, court commissioner would decide, and either side could appeal an adverse decision to the Superior Court. So if you were asked the question of what's the legal ruling in California that addresses medicating mental health patients against their will, the answer is Reese versus St. Mary's Hospital. And they must be given a hearing unless it's an emergency situation. All right. In your reference packet, we won't go into it, is a bunch of sheets that have to do with interdisciplinary checklist, requests for voluntary admission, probable cause hearing, a mental health conservatorship for California, consent to release, request information. It's all there as reference material. There's no reason that you need to look at it, but just know that it's there. My last patient story before we shift to cultural issues is an Air Force pilot that I saw in my private practice, prescribed Zoloft for depression. And her story in a nutshell was that she was a fighter pilot, and her commanding officer warned her that she was going to get a drug test to prove that she was not taking any psychotropic medication, because in the Air Force, you could not be taking any mind-altering medication and be a pilot. You would be kicked out of the Air Force. Her commanding officer knew that she was taking Zoloft, and he warned her that she was coming up for a blood test in about 2 months and that she needed to deal with this. She was a superb fighter pilot. She persuaded me in my outpatient practice that she needed the Zoloft to be at her best in terms of fighter pilot and anxiety and depression. And what I did is I weaned her off the Zoloft over several weeks. She went for a blood test. It came out nothing there. And then I put her back on Zoloft and sent her back to the Air Force. And it was all with the wink, wink knowledge of her commanding officer, but it fit within the guidelines. And I mean, within the Air Force. Okay, so a cute little case about confidentiality. Okay, culture. So we have to be culturally competent. We have to understand, we have to relate to and be competent, at least in theory, about the language, thoughts, communication, actions, customs, beliefs, values, and institutions of different racial, ethnic, religious, or social groups in order to do our job properly. Now, DSM-5, published in 2013, it replaces the notion of culture-bound syndromes with 3 cultural concepts of distress. Cultural syndromes, cultural idioms of distress, cultural explanations for distress. Rather than merely listing cultural syndromes, DSM-5 adopts a broader approach to cultural issues, acknowledges that all mental disorders, including DSM diagnoses, can be culturally shaped. However, it seems that some DSM conditions are more culturally shaped than others. For example, PTSD, anorexia nervosa, bulimia nervosa, depression, and deliberate self-harm that's not suicidal, but can be understood as cultural syndromes. So for being in the DSM, these syndromes are largely seen as expressions of human distress, PTSD, eating disorders, etc., and are culturally bound. So I mentioned earlier in the day that one criticism of the categorization of Western categorization or classification of mental disorders, such as in the DSM and the ICD, International Code of Diseases, is that they are arm in arm with pharmaceutical companies. They encourage the wholesale exportation of Western mental disorders, and therefore Western approaches to mental disorder, and ultimately Western values such as biologism, individualism, pull yourself up by the bootstraps, and the medicalization of distress and deviance. There's a lot of new literature out about depression. There's an anthropologist, Junko Kitanaka, um, that she wrote relatively recently, just as I talked about earlier, that depression, which was largely unknown in the Japanese population, but more of a cultural phenomenon, um, that a heck of a lot more people were diagnosed with depression recently in the 90s and 2000s. Um, and it increased psychiatrists and increased the pharmaceutical company reach. It urged people to reinterpret their distress in terms of depression. And it's now one of the most frequently cited reasons for taking sick leave in Japan, when this wasn't the case in the past. So if you were asked this lob question, DSM diagnoses should be made devoid of cultural considerations, I would hope you would say, no, it has to be, it's false. Cultural considerations are part of everything, and they color everything we look at. Okay, I need to read Amber's, or also, I want to see what Amber said. Hang on just one sec. Oh, happens. Just call it waivers, right? In an emergency situation, is there ever a benefit for an IM versus an oral? Faster, stronger for oral? The faster or stronger is the IM than oral in emergency situation. We had a patient who had a pattern of escalating, and the doctor wanted an emergency IM, even though the patient was willing to take oral. So this is a very difficult very difficult question, and there's no easy answer, especially in a short amount of time, because at some point you get kind of punitive with the patient, or you want them to take an IM. You made me suffer, so I'm going to make you suffer, and you no longer have the right to take an oral. Well, I really recommend you look at your own biases and step back from the situation and try to assess it objectively. Is how much benefit, if a patient's going to accept it orally, they were bargaining with you and they realize you're not going to budge, and then they say, okay, you made me, forced me into this predicament, I'm going to take the oral, and then you say, no, you're not, you're getting the IM. I find that a little punitive, and so I would question that. So all I can say is try to be as objective and non-punitive as possible, and what's the right thing to do clinically. Yes, an IM has the potential to act more quickly, no question about it. It enters the bloodstream faster, but does that 15, 20 minutes make a difference? It may make all the difference. It may make no difference, especially if they're in restraints or they're in seclusion and they can't hurt themselves. So take that into account. What would be the risk of giving another 15 minutes? I would be inclined to give it to them orally, but that's just me, and I'm older and maybe a little bit wiser. All right. Okay. So moving on, cultural competence continuum. I find this really interesting. We're heading from cultural destructiveness. Now I'm thinking, think about the conquering of the Americas by Spain and Portugal way back when. And I went on a trip, not last year, but the year before, to San Miguel de Allende, and learned a lot about the Native American population in Mexico, that before the Spaniards came, they had a population of approximately 20 million Native Americans in Mexico. And within 100 years, there was 1 million Native Americans. They had all been killed off by disease, mostly, and by famine, and also war, and just killing them. So talk about cultural destructiveness. 50 million Native Americans in all of the Americas were died off within decades of invasion by the colonists. That is cultural destructiveness to the max. So there's levels of this, of cultural incapacity, cultural blindness, cultural pre-competence. We think of addiction as, Prochaska and Prochaska and can't remember his name now, of DiClemente. Thank you very much. Very good. It's getting late. Of are they, readiness to change, and are they competent or pre-competent? So cultural pre-competence, are they ripe for it, but they're not there? And then there's cultural proficiency to the extreme. Very important to identify which is which. So the last question of the day has to do with currently and for decades in the past, the US mental health system has exported its diagnostic criteria, DSM, and psychopharmacology to foreign countries and their healthcare providers. Unintended consequences may include a loss of indigenous beliefs and customs regarding explanations for distress, sure. Social and family disintegration, sure. Contagion effect and spreading of symptoms. So I would guess D, and that's what I said. Yes, and you did too. So very good. So in your journey through cultural competence towards cultural competence, essential elements of the journey are your own self-assessment. What are your own biases and prejudices? When I grew up in Walnut Creek, California in the 1950s and 60s, the first Black family moved into town down the street from us. I had never really seen close up a Black person. That's how racially segregated the world was back then, particularly in the suburbs. And my dad asked me to met the mother, a single parent mom who was a nurse, and to take her daughter, Vicky, who was my class in the 8th grade, to school, to walk her to school. And I at first refused. And I refused because of my own ignorance and my own bias and my own prejudice, because she was Black. And my dad said, who was also prejudiced, but a little bit wiser than I, but I inherited his kind of view of it, said, what do you mean you're not going to take her to school? This is what neighbors do with neighbors. And of course, I took her to school. She became a friend, and we were buddies after that. But it had to do with prejudice and bias. And I'm embarrassed to this day to admit it. And I think about her every once in a while. Vicki Cowan, and what happened to Vicki Cowan? Humility, to know our own limits, to value diversity, vigilance toward the power dynamics that result from cultural differences, responsiveness to cultural differences, and adapt our own assessments and treatments as a result. So I'm not going to spend too much time on this. We're running out of time, but there are striking disparities in the mental health care found in racial and ethnic minorities. And you can see in these bullet points some of these points. So it creates an increased disability burden for racial and ethnic minorities. So what do we do about it? We negotiate and manage a treatment plan to maximize adherence and compliance. We look at the context, biological, psychological, sociocultural. We use some of these acronyms like LEARN. We listen, we explain our perception of the problem. We acknowledge, we recommend treatment, we negotiate agreements. Will the case for the essay be on Moodle? Rebecca asks, I believe so. Aiden knows the answer to that. I sent it to him. And so I believe Aiden's going to distribute it to you, as well as the post-test and the case study and the 2-page review article. Right. Yeah, it's there. Danielle says.
For between weeks, I have already set it up.
Right.
The vignette, and for tonight, there's also an assignment based on a short article.
Okay, but not due for 2 weeks.
Not due for 2 weeks. Yeah.
Right. Okay, great. So here's another acronym. ADHERE. We acknowledge the need for treatment. We discuss potential strategies. We handle questions. We evaluate the patient's functional health, literacy. We recommend treatment. We empower. These things are a little bit corny, but I think they're, the article's due in 2 weeks. I think these are helpful just to keep in mind. So a culturally informed treatment plan looks at the different pharmacodynamics and pharmacokinetics that may vary due to genetics, diet, environment, interaction with verbal medications. We look at medication adherence and compliance strategies. Maybe they don't like the Western approach. Maybe they do love the Western approach, even if they're not in a Western culture per se. Maybe they immigrated into a Western culture and embrace it for that. Doctor knows best. Maybe they didn't. Are there other approaches such as acupuncture? In psychotherapy, this is a great line from Evelyn Lee, an educational psychologist or an educator, PhD educator at San Francisco General Hospital. Be the tiger balm oil at the first interview. Be pleasant, respectful, inviting. Have them teach you their culture. Should you do family therapy or individual or group therapy? Depends on some cultural influences. Should you use supportive or cognitive behavioral or dialectical behavioral? Insight-oriented, which should you use? What cultural modifications should you make? And what therapist characteristics will help you or hurt you in this treatment? Okay, sociocultural approaches. Utilize the cultural strengths when possible. I mentioned the case of the Taiwanese girl 6 months ago, where we brought in the minister to do an exorcism while she took medication for her psychotic depression. And I can't tell you what worked, but it did work. We work within other systems of care, such as faith-based organizations, primary care, school, vocational settings. And here's an interesting article on children, medication, and meaning that is really from the other course. The bigger the pill, the bigger the problem, and vice versa. What's labeled? I'm fascinated with LSD and their different monikers for LSD. There's a cult around it, if you will, or certainly a culture around it. So the meaning of medication. So only sick or bad kids have to take medication. And who administers the medication? Is it self-administered? Who is the agent of the doctor, etc.? What's the frequency? Is it better to take it, outside of the school hours, etc.? Some of these things we talked about in the other course. All right. And then finally, we have the slides on interprofessional issues. Who owns the patient? And who is in charge? How to collaborate and communicate with the treatment team? Is it a formal? Is it an informal consultation? What are the rules? And potential pitfalls with psychological splitting, shared responsibility. People are pointing at each other. It's their fault. It's not my fault. This is stuff that is really heady stuff and important to sort out. Okay. And then finally, this is the final slide, is on impaired professionals. Impaired professionals, that's a difficult topic and one that deserves its own several hours, but we're only going to give it a couple of minutes. Is there are big barriers to treatment for chemically dependent impaired professionals. They often hide the signs of impairment. They often have greater access to prescriptions, like nurses and you know, the ones that abuse medications the most as a group of professionals are dentists, because they have access, laughing gas, narcotics, etc., for pain control. Drugs are diverted to the street, and interventions are very difficult. If you get busted as a professional, it will jeopardize your future, your career. But I have to tell you that the health professional caught using a prescription narcotic without medical justification rarely will lose their license. State boards, professional boards, bend over backwards in general to keep you on the books. There's a lot invested in you, in your career, and you're helping the public. So the chance of you getting kicked out of your profession, you have to work pretty hard to get kicked out if you're an impaired professional. You have to keep blowing it with random talk screens blown and stuff like that. If you toe the course, do the time, acknowledge it, fess up, and the rest, in all likelihood, you will be restored to your practice. So, ladies and gentlemen, I think that's it for the course. Thank you, Eddie. Peace and blessings to all indeed, especially with this coronavirus pandemic. You all stay safe, socially isolated. It's been a total pleasure. I really love teaching this course, and I wish you all the best. Do well with the exams. There's not going to be any tricks about it. You'll be fine. Just put in a little time. And thank you very much for your interest and participation, and good luck in your futures. And if there's anything I can do for you, you have at the front of my syllabus my email address. When will the exam be posted? Aiden, I think, has the answer to that, but I believe he's going to post it very soon.
I'll probably do it by Tuesday.
There you go. Okay, very good. Thanks so much, Aiden, for your great help. Without you, I don't know if we could do it. So,
my pleasure.
All right. Everybody take care, and hope you all get through this tough time we're going through. Okay. Thank you again.